Now, I just want to tell you about two patients who I think, in a way, epitomised the whole story of they want to end their lives, okay? One 84-year-old woman who had said, right, I've had enough treatment, I'm not having any more, I've had a good, fulfilling life, that's it, I don't want to be a burden, now in pain, bedbound, dependent, can't stand this, difficulty getting from bed to the commode, I just want to die. And quote, if that nice man, Lord Joffrey's bill, had gone through, I would have assisted suicide. No doubt about it. Crystal clear in thinking, speaking like that for weeks. So I'm just going to ask you to hang on to that one. The other young man came in with his wife as an outpatient. I know my own mind, and his wife supporting him. He was going to go to Dignitas, but he needed pain control to get there. Absolutely certain that's what he wanted to do. And his wife was supportive and said, well, if I get tried afterwards, so be it, that's what we're going to do. He is absolutely clear he doesn't want to live through his illness and die of his illness. He doesn't do dependency. He's fiercely independent. So hang on to that one too, and I'll come back to what happened with them. So just picking up on that, I just want to die. I think it's worth remembering that there is a power differential between the clinician and the patient, irrespective of how much the clinician is trying to empower the patient. There is, because the clinician's got more knowledge, they're standing back, they're well, the patient is ill, and they're vulnerable. And however much you try to empower patients, it's inevitable. And there's a danger that you can try to empower them so much that you end up dumping decisions on them and making them feel that, oh, crumbs, it's all up to me. Because patients actually need guidance. They rely on you having good professional knowledge. So I think it's a bit like being on a tandem. Some of you will have seen Andrew and me on a tandem going down to Cardiff Market sometimes. Andrew has the handlebars. I'm like the patient on the back. I am completely vulnerable. He steers wherever we go, and he nearly took us into the river once. But you know, I am just like the patient on the back. Normally, and I put a woman on the front of this tandem because actually most healthcare professionals are women now. But the patient is on the back, and whoever has got the handlebars is in control. And the way you steer that consultation determines which road you go down. And whatever, if somebody says to me they want to die, I need to reflect back to them what they're saying. Do they really want to die? What's behind it? What's behind that request? I need to listen to what their concerns are. Listening is really, really important to what comes in. But then, and I've seen this in those countries where the law has been changed, you can process the request. So you go down a road of saying, well, I'll process the request, and at that point you give a subliminal message that yes, you are right to think that you would be better off dead. Or you can say, but what is it that's making today so terrible? However small it is, whatever it is, what can we do to improve today? And is there anything at all? And the message there is a subliminal message that you are worth me working hard for. And that becomes a really important message, because the things that break people are the little things usually. It's not the big ones. It's the things which are really difficult. Now, why is stopping a treatment not killing patients? I just want to try and explain that to you briefly. Patients have got their disease, and when we stop an intervention, we are stopping it because it's not achieving a therapeutic end. It's futile. And when we stop it, they may die very quickly. There'll be people on a ventilator, you'll take them off a ventilator because you're not achieving any goal. Nearly all of them die very quickly, but not all of them. But quite often when we agonize and stop treatment, actually patients get better because we realize it was their treatment that was making them worse. The treatment was making them worse than the disease. Now, I've had the situation of in Llandoch taking a lady off a ventilator in ITU with the team there, expecting her to die, but she started breathing. So we said, okay, well, let's put an oxygen mask on her and take her across to Home Tower because she was going to die within the next few hours, but ITU wasn't the appropriate place for her. And fast forward 2 days, and she was sitting up having breakfast. And she then became the official welcomer of new patients in Home Tower. And she welcomed them and their families and said, it's not a one-way ticket here. Lots of people go home again. And she took a pride in showing families where the facilities were to have something to eat and drink and so on. But the thing that was interesting is in all of that, she said, I now have a role in life. And she suddenly realized that she was contributing to society when, in fact, before being on the ventilator, she thought that her days were up and she had no role. And she was on the ventilator because she'd attempted suicide, but had failed. And the only thing she said is, please don't send me home again. And she had been terribly lonely. So we let her stay. And she stayed in Home Tower until she died several weeks later. But she did greet an awful lot of patients and families in that time. And she began to get the information booklets and take them around to people and all kinds of things. But the reality is that most of the time we agonize over these decisions and patients die of their disease when they're going to. And that could be at any time. And that is fundamentally different to saying that you're going to give a drug to deliberately end somebody's life, irrespective of how long they would have lived for. And that's emerged. One of the Dr. Martin patients, certainly, he was getting the car out the garage, I think, the day before. Doesn't sound like he was just about to die. But this is about deliberately killing somebody as fast as you possibly can. And that's fundamentally different to stopping a treatment, and I hope I've made that clear. Dignity is a word that's bandied around a lot. And dignity is about having a sense of personal worth. This was Cicely Saunders' definition, and I think is probably the best I've ever come across. We all know when we lose our dignity. We expect to have our dignity. We don't go round saying, I've got more dignity today, my dignity levels have gone up, but we know when we've lost it. We know when it's been taken away from us. We know when we have been treated in a dismissive way, when people have spoken over us, spoken down to us, been dismissive instead of being supportive. And indeed, Harvey Chochnov has done some very good research showing that the way that people are cared for and are reacted to either enhances their dignity or strips them of their dignity. So people as patients are really vulnerable. And we hear it, don't we? You hear it in complaints that people make. You hear it in stories that come out through the media of people saying, they treated me as if I was a sack of potatoes. You know, they ignored me. They treated me as if I was just a case on a conveyor belt, not as a person. That strips people's dignity. And part of the drive that we've had with the palliative care services in Wales has been to drive up the standard of listening to patients and the standard of respect of the individual, whoever they are, wherever they are.